It's 8 o'clock. You ready to get started and introduce ourselves?
Yes.
All right, I'll start. My name is Keisha Shepard. I am the co-chair of the Health Committee with the NAACP of Howard County. This is our first event that we're hosting, and we're very excited that all of you have decided to take your Wednesday evening and spend it with us. We're really hoping to grow our committee, and that if you are interested, we will be asking you to fill out a flyer to let us get your contact information so that you can do that. A little bit more about myself. I grew up in Howard County. I graduated from Oakland Mills High School. I'm a Morgan State graduate, and I currently am a software engineer. So those are little things about me, but I really do care a lot about the health of the community and how we can afford health care, and different Medicare for All issues are the things that I am very passionate about. Jerry?
I'm Jerry Residio. I think people have seen me in meetings, and I've been in Columbia for about 4 years, and I was a member of the Health Committee for 3 years. So I was glad that Keisha and I could team up and go into this next year. So my feelings, that it's totally right. Tolu was saying that he was interested in the insulin for all. I think we need those kind of inputs. One of the things that I think are very important for us is we have to basically, for one thing, understand what are the needs of our members and of Howard County African Americans. And those are, there's an awful large population of Howard County African Americans. And so I think we have to understand the needs. Dr. Sriram is here, and he's going to offer, I'm sure, a solution to how we meet needs. And I think that's what we have to do, is we have to be active in finding solutions that will work, again, for Howard County and for our membership. And the last thing I think is very important is that it seems like there's just not enough communications that with our members and communications with people who are actually in the trenches trying to take care of their health care in Howard County. So I really think those are things that I would like to see. I think we need a good deal to be in the trenches with people who have needs and communicating with them, and also communicating with people who have solutions. So that's my thinking for the coming year.
Yeah, so that is, we just introduced ourselves. I want to just let you know kind of some housekeeping. Please keep yourself on mute if you are not speaking. If you have a question, go ahead and type it in the chat, raise your hand, or just unmute yourself and ask if it seems like a good point and time to do so. We'd like this to be a conversation. We want to make sure that we get to know the people in the community and the things that they need. So if you wouldn't mind doing those things, that will keep things pretty much in order. Also, how this event is going to go, we're going to have our president speak about different things that are going on and initiatives that are happening for the NAACP first. Then we're going to have Kristy Fogle. She's going to speak about all the different things that are going on legislatively with Medicare for All. And then we want to have a group discussion with everyone about their healthcare needs and what they want for the community and how they would like us to move forward. And also, lastly, we have our guest speaker, Dr. Sanjeev, who will speak after that. So we want to keep this meeting moving quickly and everything. So let's get started. Willie, I saw you just signed on. Would you like to talk about some of the initiatives, some of the things that we're doing, such as the community garden and the bikes for kids, and I guess also the upcoming weekend, with all the different things going on as well? You're on mute.
Unmute. Can everybody hear? Good evening, and certainly happy to be here. I want to acknowledge the organizers who have kind of adjusted to everything going on in the quarantine world and established a platform on Zoom, which is fascinating. And I'm sure everybody has been on enough Zooms to to make you love being in front of a screen as if you're really talking to people. But I want to just say that, you know, as health is one of the most significant social determinants of health, it's important for us to, as an organization, as the NAACP, to organize around health. And it just happens that we have two organizers who are very interested in this subject matter, and it's significant for us for a lot of reasons, because health, you have to be concerned about health from the time before you're born. So to position in such a way to have a place in to influence the policy is significant for us as a civil rights organization. So it's very important to have a platform to highlight the details of health, not just, and in several levels. Health is so complicated that it's in several levels, but to talk about policy is significant because that's the throughput that we can do with advocacy from our members. So I'm very proud that Keisha and her committee have put this into place, and I hope that we can grow from here. For a long time, we didn't have a health chair, and so I'm happy to celebrate this opportunity. But as you know, with what is happening with COVID-19, it has put health in the forefront like never before. As it pertains to the Howard County branch, we've positioned to itemize the social determinants of health in such a way that, some stuff we didn't plan. We had an environmental and justice, climate justice grant that allowed us to create a community garden and to basically prepare to do a long-term effort with a community supported agriculture project that will allow us to have fresh food, which is a big deal, that we will have locally grown chemical-free food in a format that allow everyone to participate. So look out for that. In addition to that, we discovered that another social determinant of health, which is transportation, which is I overlooked, but it is a key social determinant of health. And we adjusted with an organization called Free Bikes for Kids to not just, it wasn't even a plan to be concerned about health, but like I said, it's an obvious social determinant of health if it's the case that if you don't have transportation, you can't get to the job you need, you can't get to school, you can't get to the doctor. And if you learn it early, and we did it in this case with young people who didn't have transportation, they were able to learn the value of the freedom that comes with being able to have a bicycle, which is, like I said, I overlooked it, but it's significant. So we created a relationship, not just with donors in Howard County, which is key, because everybody wants to get stuff out of their basement, right? But we were able to create an exchange with Free Bikes for Kids with not just residents of Baltimore City, but residents of Howard County who were not able to afford bicycles. Because what's happening with bicycles, I discovered, I didn't know that not only are there no bicycles currently that you can buy, but even if you have a bicycle that needs to be repaired, it takes a while. So Free Bikes for Kids was literally, not only were they taking donated bikes and repairing them, they were also repairing bikes that people had. So for us to serve as a conduit to that type of enterprise was a significant breakthrough for us, and it showcased that the NAACP is in more than one place at one time. So, again, this connects with health because it's at the bottom line. So so activities like these allow us to transfer all of that information and to create and expand our network so that we're more than just one thing. And I want to reinforce here that we're more than just civil rights in the courts, civil rights on the front lines. If we don't get into the communities, we cut off an opportunity for the NAACP to expand. So again, using this platform and using talented people like both Keisha and Jerry allow us to expand what the NAACP is about when everybody else is asleep. So I want to acknowledge the organizers, the producers, and everybody on the committee who put this program into place. And I wish for the best information to come out of it today. So thank you again. And I guess I was supposed to say, look forward to this Friday evening at Long Reach Shopping Center. We'll be doing a viewing of the movie called The 13th, consistent with everything that's going on with the conversation about mass incarceration, the prison industrial complex, and aggressive sentencing. The movie puts that into place, shows the history of the 13th Amendment specifically, and basically how it basically expanded slavery in another name. So it's valuable information. It's a rallying point for young people to understand the history of not just America, but the history of slavery and sentencing, which is also important because, there was lynching in other names without literally lynching you. And the criminal justice system, as we all know, is a place for that. So it's a valuable conversation to inspire young people to do this work so that we can continue to have people like Keisha, for example, who was a member of the youth council, and she's still doing the work of the NAACP, and that's very important. So thank you, and I hope you enjoy this program.
Thank you, Willie. That was great. I just wanted to stop real quick and ask if anyone had any questions for Willie before we move on. Lenny, go ahead, and Leonard, go ahead and unmute yourself. You're muted.
When and where is the movie? And if it rains, where is it going to be held?
We haven't planned for rain. So it's going to be this Friday, 8:30 at Long Reach Shopping Center. We haven't planned for rain. So if we miss it this week and there's a cancellation, I guess we'll do it the next day. But the following week, we're also doing a jazz, funk, hip hop, spoken word event that's going to be live streamed. And then just check our site for that. But it's going to be a combination of a jazz show with various artists who do both spoken word and hip hop as a part of what, I don't know if Keisha told y'all, but they created an organization called the Pipeline, which is a group of young professionals in the NAACP with the sole goal of taking over so I don't have to do all this talking anymore. Go out and mow the yard.
Yes, yeah. Basically, Willie sends us a text and it means get to work. So he's gathered a group of young folks that are really doing amazing things, and some of them are on this call. So I want to thank you guys for coming. And I think Leslie Turner, I think I saw that you wanted to ask a question.
Well, I think Willie answered it, but is it outside or is it indoors at Long Reach?
It's outdoor movies specifically. I mean, we kind of have opportunity. You can literally watch it from your car if you can get synchronized that way, because the sound, there's some app that allows the sound to go to your car, but the goal is to be outside. And it's, I guess I should emphasize that it's a significant opportunity for social distancing. So I guess that's important to everybody.
Yes.
As you know, Long Reach is a big parking lot, so we'll be able to accomplish that.
Okay. I don't think there were any other questions, so I would like to move on to Kristy Fogle. Kristy Fogle is a part of the Maryland Progressive Coalition of Healthcare, and she has been working so hard, and she was a great help to me on the other event that I did. And I asked her to speak about some of the things that we're doing and what's going on. So she is a nurse as well. Kristy, I'll let you introduce yourself.
Physician assistant. Close, physician assistant. Thanks, Keisha. Thanks for having me as part of this important discussion. I think these types of discussions are extremely important. Just to get a little bit of a background on myself, as Keisha said, I'm actually a physician assistant, and I founded the coalition, the Maryland Progressive Healthcare Coalition, which is comprised of over 30 state and national organizations, of which Keisha is a part of. So we're healthcare activists, we're progressive organizational leaders, and we're healthcare providers like myself and Dr. Sriram, who you're going to hear from shortly. We're focused on the legislative fight for new and improved Medicare for all. The purpose of this coalition is to unite the efforts of all the organizations who are working in Maryland on Medicare for all and to build power together around single-payer healthcare, both in Maryland and on the national stage. So I want to set the stage for the rest of this conversation tonight about healthcare. Our healthcare system that we have is extremely expensive. We spend almost double what other countries do, but we have poor health outcomes in those countries, and these are peer countries to ours. We do not provide universal coverage as a right. And the system is riddled with racial and economic disparities, which Dr. Sriram is going to delve into a little bit more in his talk. We currently have this system, and the pandemic is highlighting this, where we have insurance companies who are increasing their profits by denying patients care. And I see this every single day at work. In fact, in the US, health insurers have doubled their profits in the second quarter of 2020 compared to 2019, so due to the pandemic. We also have socioeconomic disparities, which people essentially become trapped on state Medicaid for fear of getting kicked off of the only health care they have if their income increases. So this is prior to the pandemic. Prior to the pandemic, we had a staggering 30 million people who were uninsured and another 40 million people who had insurance, but they couldn't afford care, whether it be copays, premiums, deductibles. And this was pre-pandemic. So fast forward to COVID-19, and per the most recent numbers that have come out, we know that 50 million people have filed for unemployment this year since March. And here in Maryland alone, it's been over 500,000 people who have filed. And now we're learning that over 5.4 million Americans have abruptly lost their health insurance coverage, which was previously tied to their employer. So the number is projected of that to go over 40 million people by the end of this pandemic. And when you add this to the 70 million that I mentioned previously that were uninsured or underinsured, you can see this is a crisis situation that we are in at this point, where over a third of our country could be without health care at the time where they need it most. So this pandemic has highlighted and it's underlined every problem that we have with this for-profit healthcare system. And we can see now more than ever that we need universal healthcare coverage. And we need something that's not tied to our employer. We really need new and improved Medicare for all. So last year in February of 2019, the most progressive and comprehensive piece of healthcare legislation in our nation's history was proposed. And that's H.R. 1384, the Medicare For All Act of 2019 by Congresswoman Pramila Jayapal and Debbie Dingell in the House and Senator Bernie Sanders in the Senate. This bill would establish a national health program and prohibit cost sharing, deductibles, coinsurance, and copayments. This would also improve Medicare by adding vision, dental, hearing, and long-term care coverage. And last year, we had 4 historic hearings in the House on this bill. At last count, after the death of Congressman Elijah Cummings, we have 118 co-sponsors in the House on this bill, which is really historic. And in Maryland, 4 of our congressmen have not co-sponsored this. Congressman Steny Hoyer, Dutch Ruppersberger, David Trone, and Andy Harris have not co-sponsored, but Congressman Raskin, Browns, and Sarbanes have. And also, the late Elijah Cummings did sponsor this bill proudly. At this point, we have not seen any co-sponsorship by Kwesi and Fume. So we know this is the most progressive and comprehensive piece of healthcare legislation in our country's history. And since the Medicare for All Act was presented last year, this coalition has been heavily focused on promoting it through public education, town hall events, educational webinars, and conversations like this. We work on the national strategy and messaging with Congresswoman Jayapal's office, and we also work with state representatives like Senator Jill Carter, Delegate Gabriel Acevero, and Delegate Sheila Ruth, who are all members of the coalition. Several of them have actually spoken at our recent town hall events this year. So right now in Congress, there's a battle, and it's a battle between the progressive members of Congress who are trying to achieve some real protections here for patients, and the members of Congress who are willing to bail out the insurance industry. There's several bills that have been floating around in Congress that include some substantial protections, not for the patient, but for the employer-sponsored insurance plans. And these bills are being heavily lobbied by the insurance industry. So right now we need, and we're pushing for, is for our Democratic leaders in this crisis to stand up for the people of this country and not for the private insurers. That's why we're here in this coalition, is to hold them accountable. So that's going to bring me to the end of what I'm about to say here, which is that we want you to get involved. So the time right now is critical to build this movement. We've got to build this movement. We are heavily working on base building here in Maryland, and we are also in contact with coalitions throughout the country who are doing the same thing in their states, that are applying pressure to their representatives and highlighting the racial disparities in our healthcare system. And we want to elevate the discussion around Medicare for All, even after this election. So the next step is we are currently working on a racism in healthcare webinar, which will take place virtually in September. And if you'd like to join us or be involved, please let Keisha know, and she'll let you know how to connect with us. We welcome any group, any organization, or any person who just wants to build power around Medicare for All, because that's why we're here. You can follow us on Facebook, Instagram, and Twitter. I have to put my little plug in, and also at mdphcoalition.org.
That was great. Does anyone have any questions for Kristy? Tolu?
Yes.
I unmuted you. Go ahead.
Oh, yes. First of all, hi, everybody. I was discussing this with OR, but it's just that I think with Medicare for All, which I don't support, we're in for the fight of our lives, because I can already see the hummings of MSNBC, CNN. They're literally getting their talking points ready about how bad Medicare for All is. They're already going to get Joyanne Reid and they're going to get every single black person on MSNBC, on CNN, that listens that because Medicare for All was written by Bernie Sanders, a white man, it's automatically racist, and you are basically eliminating Obama's legacy. Like, do you have anything for that fight? Because that is what's going to be blasted 24/7. And the minute that 2024, the minute that, let's say, God willing, AOC or someone else, every single of the black pundits are going to say, how dare the progressive movement challenge the first black women? They are all racist and sexist. And we know these attacks are going to come. We know these attacks are going to come.
Thank you,
Yeah.
Tolu.
We deal with these attacks all the time, and I just want to quickly say that one of the things that's important from a messaging standpoint to say when this is brought up is the Affordable Care Act was a step in the right direction, right? So we're not going to deny that the Affordable Care Act made some important, steps forward, some regulatory steps forward. But where it fell short is by keeping the profit in healthcare. So the nature of healthcare right now, and Sanjeev can tell you the same thing, anyone who works in healthcare can tell you this, is that it is for profit and that the focus is on profit. It is not on the patient. And so the Affordable Care Act did not change that. And this coalition and anyone who's working in this movement will tell you that we cannot fix the disparities, we cannot fix the issues within healthcare without removing the profit motive from healthcare. We can't do it. It's not possible.
Keisha, I wanted to ask Kristy a question.
Go ahead.
Kristy, so the question I have is, you offered one possibly short-term need, and that was that people can be kicked off of Medicaid by earning too much. I mean, do you have any other needs that you could look at that could be addressed on a short-term level? Because certainly the legislation is going to be is longer term. We're in the middle of COVID, and people are in difficulty now, and we're going to be probably in difficulty going into next year. So I like that one thing about the uncertainty in Medicaid. Do you have any other short-term things we should be working on?
Yeah, so actually that brings up the point that a lot of people are talking about is like Medicare for All is not going to pass tomorrow, right? So what do we do today? And so what some states are doing is they're expanding Medicaid. So they're expanding the amount of people that can get on Medicaid, and they're increasing the income threshold for Medicaid. And so that's one really great way at the state level that we can provide short-term solutions to this. There are some bills that are floating around Congress, like the Healthcare Emergency Guarantee Act, which is like the emergency version of Medicare for All. It hasn't picked up as much traction as we would like to see, but you know, it's something we're talking about in the coalition, is how do we organize and how do we push our state representatives in particular to talk about expanding Medicaid. So that's one big thing.
And can you mention that act again? You were just saying that you were pushing on a short-term basis. What is that one?
The Healthcare Emergency Guarantee Act.
Healthcare Emergency Guarantee Act. Okay.
Michael Butera had his question next.
Yeah, thank you very much. Just very quickly, in terms of coalition building, how are you doing with labor unions who have been kind of wishy, because they usually negotiate pretty significant health care, much better than most people are used to having. So what's the activity there to bring them on board? Because they could be a powerful partner, or they could be a real problem in trying to get the legislation you're talking about.
Well, one of the largest unions in the country is actually, one of the largest labor unions in the country is actually one of the pioneers of Medicare for All, and that's National Nurses United. So they talk a lot about this, and they talk about the fact that, you know, along with Labor Campaign for Single Payer, talk about this exact issue, is how do you convince unions, like you said, who have argued and fought and bled to get these benefits, to potentially take a risk. And the way that we do that is we talk about new and improved Medicare for All and the differences between that and health insurance. They couldn't be more different. It's not even possible to put them into the same category or the same realm. No amount of private insurance that you have that's employee sponsored is ever going to cover the amount that Medicare for All would cover, you know, especially the long-term care aspects of Medicare for All. That's one of the biggest things about Congresswoman Jayapal's bill that was kind of landmark. So, you know, the ability to stay in your home when you get older and to not have to liquidate your assets and get on Medicaid and go into a nursing home. And that's something that private insurance, even if you're in a union, will never help you with, ever.
Just a quick follow-up. I want to use myself as an example. I'm for Medicare for All, so get that out of the way quickly. I retired from a labor union which had insurance which covers me and my family for the rest of my life. My wife had an operation that was almost $400,000. Our exact copay was $5. When I get a prescription, my copay is $3. Pretty tough to beat, and I think that's part of the problem. So I don't know how, I mean, I understand the point you're making, but I think you need to talk to some people who have this coverage who can tell you a story like mine. Because even with Medicare for All, as it's currently constructed, it wouldn't be better than what I have. So, and I'm old enough to be on, so my insurance is a secondary to Medicare, because you know, I passed the magic age mark, but it covers just everything. And that's just not true of all the bills. I think that's why there's a problem, is what I'm trying to do. And you need to figure that out in order to win that battle.
Yeah,
great point. The next person that has a question is Lenny.
Okay.
I have two questions. One is, I didn't vote for him, but Rupertsberger, how could he not support this? And what do we tell him?
Well, what we've found with the congressmen who have not supported this is that many of them do take corporate PAC money from the insurance industry and the pharmaceutical industry. So, I mean, I think it's pretty clear who their allegiance, you know, lies with. We've had meetings with them. We've you know, lobbied them. We have rallied against them to try to get them to listen to us. And, you know, you get the same thing every time from them. It's just, they're not willing to listen. You can put their feet to the fire. And so it gets to the point where you almost think, you know, some of these people need to be primaried, and we need people that are actually going to stand up for the people and to not take corporate PAC money from the insurance industry. Now, Steny Hoyer or Dutch Ruppersberger, they're never going to say to you, oh, I take insurance money and that's why I'm not supporting this. They'll say things like, well, how do we pay for this and how do we do this? And when we talk to them about that and we give them evidence-based data that backs up Medicare for All being the less expensive compared to the private insurance industry in the health system we have now, there's no response. It's really just radio silence, unfortunately.
Right. The other point is Cuba has excellent health care for everybody. How could we become I would volunteer, I have some connections there, to be a connection with Cuba and us to see if they could shed light on how we could move these things forward. I've gone so far as to tell people who can't get health care in the United States because it's too costly. I said, go to Cuba and seek refugee status as an exile because you can't get health care. They thought it was, but they didn't do it.
It's not just Cuba, though. You're right. And it's Canada and it's France and many countries who have single payer health care. Americans actually who live in the North go to Canada to try to get the medications they need, the insulin. Bernie Sanders took a caravan of people to do that and show people what that was like. So,
Paul, this is going to be the last question, and then we're going to have to go to Dr. Sanjeev.
Very quick, just the comments, if I may, Keisha. On the question Michael and others brought up on labor reluctance to support single payer, I think you should refer friends in and out of the NAACP to Mark Dudzik, who lives in the county and is a friend of ours and is head of the Labor Coalition for Single Payer. He knows it backwards and forwards he can tell you what the AFT does compared to the SEIU, compared to the bricklayers. That's item one. Item two, as Kristy says, there are wonderful systems in Canada and Great Britain and France and in Cuba. I've been there 11 times. In Cuba, one of the advantages is that if you throw a rock, you hit a doctor. I mean, they have so many doctors there, and they make it easy to become a doctor, and they're very skilled. Indeed, my doctor, who's originally from Guyana, was trained in Cuba and now lives in Prince George's County. So enough said, but I just want to make those comments for Michael and Leonard and others. Thank you.
Thank you, Paul. And thank you for coming tonight also. Actually, thank everybody for coming. Next, I wanted to just go ahead and move on to the next part of our event. The questions were great. I appreciate the questions. Let's keep them coming. But let's get to our guest speaker. Dr. America himself is here. Yay! He has spoken at one of my previous events, and he was really, really good. And I've seen him speak multiple times about this. He knows the ins and outs of the racial injustice in our healthcare system. I've asked him to also speak specifically on Howard County as well. And yeah, Dr. Sanjeev, if you wouldn't mind taking the floor, I'll unmute you. Oh, we did it at the same time.
All right, well, thank you, everyone. I'm really excited to join everyone this evening. So I'm going to share my screen, and I've got some PowerPoint slides. Just to let folks know, I put a PDF of the file of these slides in the chat. So those are available for people to use in any capacity that they want. And I can also email them to you, Keisha, so that way like they can be forwarded and
I got him, and I just re-put him out so that everybody can have them, because we've had some new people come in since you posted.
Oh, okay, great. So let me go ahead and share this. And 1 second. Okay. Okay, and can everybody see what I'm sharing? Are we good?
Yep.
Okay, great. So, so Kristy did a great job of helping introduce these two bills by Senator Sanders and Congresswoman Jayapal. You know, the co-sponsors on Bernie's bill has changed since it was originally launched in September 2017. You know, some folks, you know, use their presidential run to kind of take a departure from this bill. Others have stuck by it. Others have stuck by it, but much more quietly so. Congresswoman Jayapal's bill is actually the one that has gained significant amounts of traction in the past year. The fact that we are at half of House Democrats, you know, 1 year after she launched this thing is phenomenal. We've had a handful of hearings, you know, so when people question the, you know, political feasibility of Medicare for All, I really like to point to this success, because this is actually better growth and more rapid progress than what the ACA had at this point in time in the ACA's development. So, so when people want to question the political feasibility of Medicare for All, I point to that that her bill is a stronger bill than what the ACA was back in 2009, and it has made further progress politically than that bill did in a shorter amount of time, and it's really something phenomenal. And you know, I want to kind of quickly run through how this bill works. Because you have the slides, just know that this reference will always be there for you, but just to kind of make sure that we've all got the same common ground when we're talking about this thing. So, you know, I often hear people talk about how Medicare for All will cover every single American. And with Congresswoman Jayapal's bill and with Bernie's bill, it's significant to say that it covers every person in the United States. And the distinction is important because immigration status is a huge barrier to access and coverage. And by making the distinction of saying that we will cover every single person as opposed to every single American, I think we're actually dismantling one of the barriers to healthcare just in our language and our understanding of this thing. So it's just something for all of us to keep in mind who support Medicare for All. So the plan would be that everybody who is on Medicare, Medicaid, the Children's Health Insurance Program, the Federal Employee Health Benefit Program, employer-sponsored insurance, everyone gets rolled into a Medicare for All system, while the VA and Indian Health Services continue to operate as is, with an option to merge with Medicare for All years down the line. So Congressman Jayapal's bill has a timeline, a transition timeline, where in year one, everyone under the age of 19 and over the age of 55 are enrolled, and in year two, everybody is covered. In Bernie Sanders' bill, it's a longer transition period, where in year one, it's kids, everybody, and then the Medicaid eligibility age is lowered to 55, year two, 45, year three, and so on. What I want to point out in both of these transition periods is that the ACA actually serves the function of being the life raft, right? This is like, you need the ACA to continue doing its job while this gets constructed. You know, it's sort of, I mean, like, nobody is talking about abandoning the ACA. It's really making the ACA a transitional piece of policy and not the destination of American healthcare. This is a list of all of the benefits. Now, this is, and as Kristy was saying, this is the most comprehensive that American healthcare has ever been. And this is actually, when we talk about improving Medicare, this is the first parts are actually the most significant for seniors. The fact that we're covering dental, vision, hearing, and prescription drugs, and then the durable medical equipment and the long-term services, these are huge for the traditional Medicare population. And what I like to ask people to think of is that for those of us who have enjoyed the Avengers movies, right? the first Iron Man movie and the last time you saw Iron Man, he got upgrades to the suit, but he was still Iron Man. Like, you recognize that he, like, you know, it's like nobody like mistakes like who Tony Stark is. Nobody's confusing a Tony Stark turned into the Hulk. That's not it. The guy got, I mean, like, you know, had a suit in the first one. In fact, the original suit that came out of the cave, like, I mean, it's like this gray, clunky thing. And then by the end of Endgame, it is like, he's got nanotech. It's like, I mean, this really amazing piece of technology. And there have been upgrades throughout every movie that the suit has ever appeared in, but the identity still stays the same. It's still Iron Man. This is the same thing. Medicare, when it was passed in 1965, is not the same Medicare that we have this year in 2020. Medicare has gone through upgrades. Like, Medicare's, I mean, it had to cover kidney patients. It covered more disability patients over the years. It went through important upgrades for like nursing home standards, but like, this would definitely be the most significant upgrade that the program has ever gone through. But the idea that, you know, that we can't touch Medicare as we know it, we've always been improving upon Medicare. The Medicare that that our grandparents started out with and our great-grandparents started out with in the 60s is simply not the same program that we've got now. And that's what these upgrades are going to be doing, so that everybody can be part of the program. Okay. You know, I could talk in some detail about these payment models. It gets pretty wonky. And they are important. I just want to kind of keep things rolling, but I would say that these are the most important pieces of financing to understand. That you know, HR 1384 would set global budgets, which is a far more just and equitable way of financing healthcare. And payment rates means that you're not getting gypped by a doctor who decides that, oh, you've got that kind of coverage. Oh, well, you've got to pay this rate for the surgery, as opposed to, you know, these suckers over here who've got this El Cheapo coverage, whom I have to charge this other rate. Like, it keeps everything very uniform so that you're not getting, you know, I mean, shortchanged one way or the other by hospitals or doctors. You know, how we save money in Medicare for All is that the Medicare program finally starts negotiating the prices for drugs and devices. And the goal is really to eliminate all out-of-pocket expenses. We want there to be no deductibles, no co-pays. And the only time that there would be co-pays is for brand name drugs, so that way we encourage the use of generics. Even those, you get to $200 a year, and Medicare starts to kick in and help out again. Okay, so the how we pay for it question, I mean, you know, there are going to be higher taxes, but for people who have never been good about paying their fair share in taxes before, like, these are folks who, like, we sit in the shadows of trillions of dollars of wealth that has been exploited and taken from us. And these same mountains, these people who sit upon mountains and mountains of money, have the audacity to question how we will pay for Medicare for All, while sitting on the very means by which we will pay for Medicare for All. There will be a payroll tax for employers and workers, but ultimately the average family saves money. And for the people who have excellent coverage through their union, honestly, you're going to have such an improvement of take-home pay that, you know, that this is still the better bargain than what your union was giving you. That take-home pay means that your family now has so many more economic and financial freedoms than they do now. And I think that is what we have been missing when we talk about Medicare for All, is that, like, what do you do with money that you haven't been squandering to the insurance industry, right? Because, like, right now, the system costs $500 billion a year in administrative work. This is work that, like, is a complete waste of my time. This is like paperwork that I have to knock out for no other reason than because it is a necessary hurdle for the insurance companies to not pay for care. They set up these ridiculous labyrinths for the sole purpose of obstructing they're having to pay anything for care, and it costs on the order of $500 billion a year. Medicare for All gets those savings back. When we start paying the same prices for prescription drugs that everybody else in the world pays, that's $300 billion saved right there. And overall, when you have doctors who are not wasting and healthcare providers who are not wasting their time on paperwork and administrative stuff, like, you have better value for the work that you're getting out of your healthcare providers. And that is a monetary value that we have not really figured out yet. We don't know how much more value you get when you have physicians and healthcare providers focused on patient care, as opposed to constantly having to take, and the time and money is there. It's 3 weeks of every physician work year goes towards arguing with the insurance company. You get those 3 weeks back. $83,000 per physician practice goes back to the practice to do whatever. Does that mean seeing more patients, upgrading facilities, whatever it is? But it's not money that is just squandered doing nothing to make people healthier. Okay. Let's see. Okay. So, why do we need this now, right? Like, people feel like, let's talk about the ACA, because a lot of people point to it and it's like, aren't we doing good enough with the ACA? Now, I don't want to deny that the progress made by the ACA. I mean, this graph shows that every line represents a different ethnicity in this country. All the lines trend downward, right? Like, every ethnic group has improved coverage. I have argued before, and I argue now, that the Affordable Care Act was probably one of the most important pieces of health justice legislation for racial equity in the last, in the last 30 years, 40 years, maybe. Okay. However, why are there still gaps? Because some of these lines needed to come down more than some of these other lines. Some of these, there are as much as we see, that everybody's insurance improved, there are still persistent gaps. And we need to be honest with ourselves about where the ACA did great work, but where we have work left to be done. And a huge amount of why these lines came down is because of Medicaid expansion, not because private insurance did a better job of functioning under the ACA. And when we look at the consequences of these inequities, what you find is that the uninsured population is majority people of color. Like, we've all heard that America is becoming a majority people of color country. The uninsured America is already there. Okay. They didn't have to wait till 2040. And in fact, waiting till 2040 is a huge misnomer. Huge. Because we have been a majority people of color in country of color in many ways, long before 2040. In fact, I argue that if you're only thinking about 2040, you're thinking 30 years too late. Because in my world, in pediatrics, over half of babies since 2011 have been people of color. Also in 2011, the under age 10 population became majority people of color in these 13 states. The 2014-2015 school year was the first school year that children of color enrolled in public schools outnumbered whites. That has continued since. Expanding to the adult population, starting in 2018. People of color became the majority in these dark blue states that you see here, and Maryland is one of them. In fact, Maryland is the first state on the East Coast to be majority people of color. We are ahead of New York and Florida. And in fact, when we look at Maryland more closely, what you find is that we have 355,000 people who are uninsured. 73% of them are people of color. 87% of them are working folks. 78% of them are earning less than $50,000 a year. So we have maxed out what can be done with the current system, and we still are falling horribly short when it comes to racial equity in healthcare. And then along comes COVID. And what we find is that our uninsured rate has, I mean, just skyrocketed as people have lost their jobs because, you know, tying healthcare to employment was a stupid way of doing things for the longest time. Of course, this was bound to happen in some capacity or the other. And so what you find is that, like, a lot of people will argue, well, isn't the ACA saving all these folks anyway, right? Because they're becoming eligible for Medicaid. They're becoming eligible for subsidized private care through the ACA. I mean, but it still leaves 6 million people ineligible for all kinds of reasons. And what we have to confront is that this fragmentation of system where some people have healthcare not as a human right, but as a privilege of working at a certain level income job. And because clearly it's not about work, it's about working at a level of income where, you know, it is a perk for doing that level of income that you get healthcare. You know, there are people who work just as many hours, if not more, at bum wages, getting nothing from their employers when it comes to healthcare. So it isn't just that you have to be working in order to get healthcare in this country. And, you know, every fragment of the system has some kind of nonsensical eligibility tied to it, where it is requiring you to prove somehow that you are worthy of that fragment of healthcare. You know, you have to be worthy of the private insurance industry. You know, if you're, I mean, earning this much level, then yes, you are now worthy of their coverage. If you are in order to get to Medicaid, you have to have spent down a ridiculous amount of, like, you know, the little bit of financial wealth that you may have been able to acquire. And then you have to continue to prove that you are worthy. In many of these states, every 6 months, you must line up at at a Social Security office or at the Medicaid office to prove that you are still worthy of this. So one of the things that I asked this group to consider is, let's dismantle eligibility. Let's make eligibility as simple as humanity. Your humanity is your eligibility for healthcare. The more that we try to make eligibility complicated with where do you live, what do you earn, how much money do you have in the bank, these are all things that make it harder and unnecessarily harder to get healthcare, but they have racist impacts that we have to confront. So, you know, I mean, as many of you know, this pandemic has been particularly devastating for communities of color. You know, Black and Latinx communities 3 times as likely to get infected, twice as likely to die. And we have to recognize that these inequities are structural. You know, only 1 in 5 Black workers, only 1 in 6 Latinx workers get to work from home. They are disproportionately working in high-risk environments, meaning that for the longest time, their work was, you know, we weren't labeling their work essential. It always was. You know, we've always treated them as expendable, but now that, you know, the way our class structures work, higher classes have deemed that, oh, this work is essential now. And we've trapped a lot of these workers in a situation where either they go to work and confront COVID, or they decide to protect themselves from COVID, stay home, but don't like have any kind of income whatsoever to keep a roof over their head and to feed their kids. I think a lot of the conversation about inequities in COVID have centered on these higher rates of chronic medical conditions, which what I worry about the structure of those conversations is that people have been talking about these chronic medical conditions as if there are failures of biology in the people who have them. Like if you have communities with higher rates of chronic medical conditions, that is because you have chronic issues of inadequate income, inadequate housing, inadequate food, inadequate, you know, transportation, you know, I mean, and then yes, a long history of being poorly, you know, cared for by American healthcare. And what you find is that pandemics are from failures of policy, not failures of biology. And this distinction is huge. And the more that we keep talking about communities of color and their burdens as failures of their biology, as opposed to like all of us failing in policy, the worse these disparities are going to become. Some more Maryland-focused data. This was the most that I could find from a couple of different local news sources and the Maryland Department of Health. Howard County at first glance doesn't look like it's, doing that bad with COVID, but I mean, we have 6 neighbors. And as you can see from all of our neighbors, like, this, this is a very, fluid situation. So, I wouldn't breathe too much relief from looking at these numbers. And unfortunately, I don't have data on the racial disparities within Howard County. Like, that is part of the problem that we have in public health, is that we are not getting to the granular level of county distinctions in the racial identity of the cases and deaths. But we do know about Maryland is that our Black and Latinx brethren are suffering far more than what than their share of the population. So these graphs came from NPR's analysis of a lot of public health data, and you can see that the dotted lines represent the share of these populations, and then the cases and deaths you can see just far exceed what we would expect for these shares of the population. And again, it's because most people of color cannot work from home. They're in higher risk environments, and it's a lot of our failures of policy are those roosters are coming home to roost. So now is the time for Medicare for All, and it's not about ignoring or disrespecting the work of the ACA. It's just being honest about how, yes, it's important, but it's insufficient. And Medicaid does work wonders, but I mean, that largely depends on what state you're in. I mean, I can tell you that many of my patients who have moved from states like Texas and South Carolina, I mean, their experience of Medicaid when they get to Maryland is a very different one. Private insurance is proving itself completely unreliable. And the fragmentation of our system is what is making it inefficient, unjust, and unsustainable and unrealistic. These questions of, how much money do you have and where do you live? Inequities, I mean, a huge amount of them are tied to just even asking these questions. Like, the fact that you even, that we even ask for any of this is the beginning of racial injustice in American healthcare. And right now, healthcare is a privilege and not a human right. So with Medicare for All, what we have is we have healthcare that is actually a human right, regardless of what you earn or where you live or what you look like. The idea of coverage being mobile, that it's portable, that it moves with you from different stages of your life, from job to job, state to state. You get married, you have a kid, you decide to, do a little bit of schooling and, cut back your hours. All of these, decisions should not impact your ability to access care. And under Medicare for All, it doesn't. One of the most important parts that, I kind of, very glided over when it comes to global budgets. I mean, global budgets are exactly how we start remedying this issue of, hospitals and clinics that are in that are in poorer minority neighborhoods struggle to stay open. Meanwhile, wealthy white neighborhoods get to have like a fully functional, excellently run, no problem ever. There's no risk of it closing down whatsoever. Like, that disparity ends with Medicare for All because we're going to finally start funding our hospitals more equitably. And there is actually specific provisions in both of these bills dedicated to examining racial equity more closely. One of the things that I want to always make a point of, though, is that Medicare for All does not end racism or ableism in healthcare. This is not a cure-all for any of that. There's a ton of cultural and political work that has to be done in order to, to bring that to bear. But as far as like creating structures where it is tougher for racism to survive, I strongly believe that Medicare for All does that. It creates a new environment. This is a campaign that I'm leading at Social Security Works called All Means All. It's about making racial equity a cornerstone of the Medicare for All policy and movement. We have fact sheets for every single state and congressional district, so please feel free to check that out, and I'm happy to take any questions.
Right. Does anybody have any questions that they'd like to ask at this time? Let me change my view. I can't see everybody. No one? Oh, everybody's shy. Okay.
Hi, Keisha. This is Takoria speaking. I actually have a question for Dr. Sanjeev. I was going to say, do you have any thoughts or any specific data on how this is impacting, like, specifically Howard County residents, or even anything having to do with like COVID-19 and what that looks like specifically for our county?
Yeah, you know, I wish I had better data, and I spent the last couple of days really trying to get into the Maryland Department of Health data, and it's complicated because, you know, a lot of what they collect are you know, like, they're really trying to figure out like the number of cases. They want to kind of get a sense of where are testing locations and important epidemiological work that way. But as far as like the racial disparities, I really have not been able to find that, but I think it might be more that the data just hasn't been processed yet. And at least that's what I want to believe optimistically. I think that, you know, Maryland does a better job than a lot of states when it comes to, you know, making sure that there are racial identifiers in cases and deaths. But as far as like getting it down to the granular level of county, like that's been a little bit trickier for me to find.
Mm-hmm. Jerry had a question next.
Yeah, Dr. Sanjeev, my question is, I'm on Medicare and I have a supplementary insurance. And frankly, just as you said, I really don't see that the company who sells me my supplementary insurance really does add an awful lot to the, you know, to my needs. Basically, Medicare is paying for most of the bill, and then the supplementary picks up, you know, 20%, they say. So and I pay for that supplement, I pay like $4,000. So my question is, though, the thing that I do care about, and most of the seniors I know care about, is having access to the primary care physicians that I've chosen in the past, and having access to the specialists that those primary care physicians, you know, recommend. I do know one thing, and that is I have to pick a primary care physician who will accept Medicare. And I'm quite happy with that. I've done very well with my selections there. So will Medicare for All allow for a person to have their own primary care physician and then have access to specialists that primary care physician, you know, suggests, assuming everybody is willing to take the Medicare for All dollars?
Right. So that's actually a really great question. And one of the most important features of Medicare for All and versus the status quo is that right now, choice is, it's a hustle. You know, like, we don't have choice in the system. Right now, the insurance company is going to tell you, this is your network, you know, you must choose within this. If you go outside of this, there's going to be problems, you know. And in fact, when it came to, you know, like the insurance company telling you that, your employer picked the insurance company, right? And with, you know, and with Medicare supplemental coverage, you know, you run into these same kind of problems where, you know, I mean, you might have, like in places like Maryland, you might have a somewhat stronger network depending on what part of Maryland you're in. But with Medicare for All, you know, you're going to have a much easier time because there's no in-network, out-of-network. Everybody is in the network. And the reason why I am more optimistic that more doctors will take this on is especially now with COVID, I think what a lot of doctors are realizing is that their practices were actually losing a lot of money just having to maintain all of the overhead that it takes to argue with insurance companies. You know, like, I mean, my kid's pediatrician, like, you know, I mean, like, they have to keep, you know, like, they are on their toes all the time with who they're going to take, you know, go to into contract with, who they're not. You know, this, like, I mean, the billing is simpler. The contracts are, I mean, are far simpler. And I think that because of that reimbursement, even if the reimbursement is a little bit lower than private insurance, the fact that you didn't have to hustle so hard to get reimbursed means that you can spend that time that you were going to spend arguing with the insurance company, put that into seeing another patient, and you end up, like, you know, I mean, I think getting a more rewarding revenue stream, you know, which is about even. I mean, a lot of the projections for primary care is that it's very much going to be even. And even for a lot of general surgeons and specialists, it looks like it's starting to break even. The folks who are going to struggle are dermatologists who are always taking cash, who are really, like, not operating in any of these systems. A lot of, like, you know, I mean, boutique style healthcare is going to have a hard time with this. But they were, I mean, but we have to question whether that business model was ever really about, you know, health and public health, for sure.
All right, we had one more question from Nisa. She asked in the chat if what you would do to get young people involved, like high school and college students.
Yeah, you know, honestly, I mean, I asked, like, you know, for young people to, you know, just really start to feel like how this is going to look in your own community, right? Like, you know, earlier in this conversation, people were talking about, like, you know, Cuba and Canada and you know, and other parts of Europe. And, you know, I don't disagree. It's not that it's technically wrong. You know, there's a lot to learn, actually, technically. It's just that I don't know how relevant it is to, you know, to go to, like, these other predominantly white parts of the world and expect that we're going to graft over their system to a rapidly, you know, rising non-white population here. I want Medicare for All to feel like ours, like that it isn't like a remix of somebody else's track, that, like, we compose this for ourselves, that this is, like, you know, this is about saving our community clinics. It's about saving our hospitals. And I would want young people to start feeling that, you know, that sense of identity that they build with, you know, with belonging to a community, that they've recognized that, like, yeah, that hospital is where, like, you know, I mean, my baby brother was born. That's a place where, you know, like, I mean, grandpa almost died, but, like, you know, came back. Mom had a health scare there, but she overcame. It's like hospitals are these places of tragedy and triumph that, like, are very rooted in community and connected to us in such a personal way that I would want us to, you know, relish that and build Medicare for All from that local, personal sense of community, rather than expecting that it's going to be some transplant from some part of the world that isn't anything like us.
Yeah.
Great point. The next question is from Paul. I would like, this is actually going a little longer, so let's keep the questions short, and then
and my apologies for going over time too.
So let's keep the questions short. We have 2 questions left, I think, unless there's someone else. And don't forget to fill out our survey. We do want to get an idea of what people are looking for from this committee. So after these 2 questions, I will speak some more about things that are coming up, and then ask if you want to stay on and tell me what you're looking for from this committee, please stay on. I will stay on and take those questions. Okay, Paul?
Thank you, Dr. America and Kristy, for portraying the ACA as a potentially important transition. But the media seems to think in the last couple of days that we have another transition, that we've been thrown a bone in the Democratic platform for the so-called public option. and it's a bone without any marrow, for as far as I'm concerned. There's no substance to it. It's hollow because it's a false promise from my point of view, and I want your opinion. This way, the for-profit insurers can cherry pick the most healthy subscribers and dump the rest of the sick ones on a hapless public plan, and it's a subsidy for the profit insurers. How wrong am I?
I mean, I think that has been a valid criticism and concern for the public option since the beginning of the primary. I mean, I think that what I would actually really want for the Biden team to consider is look at year one of what Bernie was talking about. Year one was you reduce the eligibility age to 55. You make sure every kid, has health care. Everybody else in between, ACA is the way that, you're going to take care of them, right? And the reason why this, to me, that year one is actually where we should be building common ground with Biden is that economically, 50 and over crowd it is difficult for them to find jobs at that age. Their healthcare is in a situation where they really need to know that it's secure, reliable, high quality. And then when it comes to kids, what a lot of people fail to understand is that one, kids are actually not that expensive for America to cover. That if we want to make make sure that every single child in this country has coverage, we can no longer depend on Medicaid and CHIP, where you've got some horrible governors and state legislatures in this country that put moms and kids through hell just to maintain continuous coverage. And it's time for federal intervention on that. And when you build a young people experience with federal coverage, and you've taken care of not just grandparents, but parents, you're building a base that people have started to have a sense of security, that it is tangible, that the government can intervene in a very meaningful way. And it completely flips scripts about what the government is capable of, right? And year one, if Bernie's plan is actually what Biden can do, if he can't do years 2, 3, and 4, I'm like, Kamala's there for you. This is a baton. If you don't really have the stomach for it, if you don't have the stones to do that part, I'm like, can we talk about year one? Because to me, when he talks about public option and everything, Bernie said that the people in between ages 19 and 55, the people that weren't getting taken care of, he said that they can buy into the Medicare that is being upgraded for that 55 and over crowd, right? Again, it creates all the issues that you are talking about, but apparently this is what Biden and folks were willing to compromise on. So I'm like, just get this part of the ball rolling, let this part of the ball move. And then we can and there's a lot there that we can build from. So to me, I think right now the public option is just, 2 words. It's not even really a policy yet. And to me, I'm like, this is the way you build a public option for everybody between ages 19 and 55, is that you let them buy into the stuff that we're going to upgrade.
It's great. Okay, and Tolu, this is the last question of the evening. We're getting really over on time.
Yeah, sorry. First of all, thank you. And let me just say this comment. If I could literally drag Canada's or Europeans' healthcare, I don't care if they're white, we need healthcare right now. So I wouldn't put that. So my question is this: why aren't any of the corporate Democrats just writing on this? Because think about it from a political strategy. Sure, you won't be taking the insurance money, but you would have literally saved healthcare. You could literally be in Congress for the rest of your life without having to campaign. You could and literally go on a book tour. That's what I'm kind of pissed. You would literally be bigger than Obama. We all know Obama runs a Democratic Party. You would literally be bigger than that. So I'm just saying, from an ego standpoint, support it because you would never have to campaign again. You could always raise money.
Yeah. Yeah. I mean, honestly, like it's there are a lot of political no-brainer parts of this. What I do see in the Biden plan is that they have decided that this time pharma is going to be like their opponent, right? Like they've decided that, okay, like Medicare is going to negotiate drug prices, which means that they have decided to pick a fight with pharma. Are they actually going to put the gloves on and like take some beating and like punch back and, you know, I mean, do some moves? Good question. But the fact that like, you know, that they've even, you know, like hinted at a target. I mean, you know, it's like one of those things where you want to give credit where credit is due, and you want them to muscle up on that, right? Like you want them to like, you know, you like now is the time for the training montage. Like you want them to actually like get into fighting mode so that when like it has to actually happen, like, you know, they go in there like, I mean, like, you know, like Rocky. And even if it is the first Rocky movie, like whatever, I mean, it's something. I mean, like, you know, throw a hit, you know, like, I mean, and that's yet to be seen. And this is what like this entire process is about, you know, like, I mean, is about like finding like, you know, I mean, the backbones that, I mean, we've been neglecting for the longest time.
Thank you.
Thank you so much. I really do want to thank you, Dr. Sanjeev, Kristy, Willie, everyone that came, Jerry, for all your help with doing this, Michael for giving me the link to the Zoom meeting. So everybody, thank you so much, and thank you for the questions. Just a few things I want to wrap up with. Our next event is going to be September 16th. It's a Wednesday, the third Wednesday again, at 8 o'clock. We are going to have Suzanne Haley and Jackie McCoy speaking about advocacy in health. So if you are interested in that, I will be putting out the Eventbrite very soon and getting all that together. So I hope to see all of you again. Also, I would like, if you would like to become a part of the committee, right now we're a committee of 2. If you'd like to become a part of the committee and help us put together events like this and help us to get different information out, we have a lot of ideas of things that we can do. We want to do cooking shows. We want to highlight highlighting the vegetables that we have in the garden. We want to talk about different things with diet and with your health. Anything, even like diabetes, like he was saying with the insulin. So anything that you would like to know, have our help with, we are trying to do stuff. Also, like earlier in the summer, we were participating with some food distributions and things of that nature. So if you'd like to get involved and you'd like to be a part of our committee, please, please, please stay on and give us your information or fill out the survey that I put in the link. I'll put it out again. Jerry, did you have any final words as well?
No, Keisha, I think you've covered it all. Thank you.
All right. Well, it's been great seeing everybody again. I've been chatting with some of you in the chat because I haven't talked to you in a while. So it's great seeing everybody. Thank you so much for participating. And again, if you'd like to become involved and talk to us, please let us know. Okay. That's it. Bye. Facebook page.
Okay. If I may say, Keisha, before we begin, if I may suggest one thing, if I may?
Mm-hmm. Go ahead.
If I may, I suggest that the NAACP push for, basically push what was called Insulin for All, because if you don't know the history, insulin was actually given to the U.S. government patent for literally free. The only thing they had to pay was a $6 processing fee, and it is unimaginable a bottle for a little tiny of insulin when it was literally given to the United States government as an entire patent for free. So I'm still for Medicare for all and lots of push, but I think that's gradual. I think that if we are going to push Biden to the left, I honestly put that as a big if. I think that's one of the things that we should at least push for, because that really affects hundreds of millions of Americans are literally dying every year because they cannot afford insulin. They are rationing insulin.
Okay, that sounds good. I mean, it sucks that everybody's dying, but yeah, we can definitely look into that. I can talk to Willie about it. Jerry,